Hello, everyone, and welcome to our billing update webinar today. My name is Melinda Gabori. I am CEO and co-founder of Healthcare Provider Solutions. For any of you who are not currently HPS Alliance members, we welcome you to our webinar today and hope you will be able to take away some very important information regarding billing and collections for both traditional Medicare and Medicare Advantage. We have a polling question we want to start our webinar with today. While we wait for some responses to that question, I want to make sure that you know Healthcare Provider Solutions is a full service billing and collections company. We also provide a full range of clinical services from surveys, mock surveys to ADR assistance appeals, ALJ hearings for denials. We also provide a full coding service for both home health and hospice. And lastly, but obviously no less importantly, the negotiation of Medicare Advantage contracts. So it looks like the polling has slowed down some, and 71% of you are struggling most with Medicare Advantage billing and collections, which is definitely not surprising. So we are going to talk about managed care billing a little bit later this afternoon, or this afternoon. It is this afternoon, actually. But I said that as if this webinar was going to last for hours. But anyway, we're going to go ahead and get started. We're going to start with some highlights from the home health final rule that does directly, the changes in that final rule that do directly impact reimbursement. The home health rule that was released November 1st did carry with it a reduction in our final rates as a result of the behavioral adjustment that CMS insists they are not going to let up on. That reduction is a 1.975% reduction, offset by a 2.7% net inflation update. That basically is going to net to a slightly positive increase in our base rates, which is fabulous, but do not rest on the fact that this is a slight increase because the war has not been won. We are continuing to battle CMS over the behavioral adjustment, how the behavioral adjustment is calculated, etc. And now all of the times that they have cut the proposed percentage cut in half. So basically every year since 2020, they have proposed a behavioral adjustment, and in most years have cut what they proposed in half before it was finalized. So since they didn't take the other half, that other half total in general has been put into a bucket of money that supposedly we still owe back. And that number is now $4.4 billion. And so there's got to be a way to pay that back per CMS, and they are continuing to work on that. We will continue to advocate on behalf of home health agencies across the nation to try and get that to go away, the clawback especially. But so if you are asked by your state or national associations to participate in advocacy regarding that legislation, please make sure you reach out to your representatives. The outlier fixed dollar loss ratio is being updated to 0.35. It was proposed to be 0.38. In 2024, it was 0.27. So today it's 27%. The fixed dollar loss ratio basically represents the percentage of excess cost that the agency must absorb before an outlier payment kicks in. Having said that, with 27% being the number today, if the excess cost is $10,000, you're going to have to absorb $2,700 before an outlier payment kicks in. Next year, that number will be 35%, which basically means, in a nutshell, you will be absorbing more excess cost before outliers kick in. So fewer patient payment periods are going to qualify for outliers. And the ones that do qualify will be a lesser payment. The recalibration of the 432 case mix groups has happened again, which means the case mix weights associated with each of the 432 possible HIPS codes has been revamped as we go into 2025 based on 2023 data. That recalibration has resulted in a budget neutrality factor of 1.0039% added into the base rate calculation, which is obviously a slight increase. Then we have wage index changes that have occurred to all the CBSA areas throughout the country, resulting in a 0.9988% budget neutrality adjustment to the base rate. Those two basically offsetting each other. We are going to talk about that information in a little bit more detail in a few minutes. The occupational therapy LUPA add-on information we will discuss in detail. So these are the rates that we will see in 2025. The 2,057.35 will be the base rate. In order to get to what you're actually going to get paid, you have to take the base rate, multiply it by the case mix weight as a result of the HIPS code identified for that claim, and then it has to be wage adjusted according to the county that your patient is currently receiving services in. The proposed amount from the proposed rule was $2,008.12, which means with the final rule changes, we are going to be up about $49 per 30-day payment period over what we had been proposed back in July. Having said that, today our base rate is $2,038.13, which you see to the left of the chart, table 21 on your screen. And that $2,038.13 now becomes $2,057.35. So in a nutshell, $20 basically per 30-day payment period above where we are today. Again, understanding that this is just the base rate, it does have to be case mix adjusted, wage adjusted before the final claim payment, which could have significant swings if the case mix weights of the HIPS codes that you typically bill for from your organization had major changes, and if your wage index had decreased. These are the 12 clinical groupings based on the primary diagnosis found on your claim. I left this in here because I want to emphasize the fact that if the primary diagnosis that you intended to be utilized to calculate your HIPS code payment is not appropriately included on the claim, you will not receive the appropriate payment. Understanding that while the start of care, plan of care, primary diagnosis should match your first 30-day claim primary diagnosis, as you move through the care of that patient, you could potentially have a change in the primary focus of care, even into the second 30-day period. The example I typically use is a patient that might have a UTI when you admit that patient, and in that first 30 days, the UTI may resolve, but you now may have a patient with an exacerbation of CHF or COPD, etc., that would require you to continue care for the patient into the next 30-day period. If the focus of care has changed, you need to ensure that the primary diagnosis on that subsequent 30-day claim gets updated. Make sure you understand that anything that happens in the first 30 days cannot impact the first 30-day claim as far as changing the HIPS code, etc. Obviously, that first 30 days visits is what is reported on that final claim, but you should not be changing diagnosis codes, etc. And then what happens in that first 30 days is going to impact your second 30-day claim. So make sure you keep that in mind. The low and high comorbidity adjustment, which is also a part of your HIPS code, the low comorbidity adjustment, 5.08% increase in case mix weight if your claim qualifies. So the secondary diagnoses on the claim, which can be up to 25 individual codes, each of those codes, they run through the tables to determine if a low comorbidity adjustment is applicable. If it is, you will receive a 5.08% increase in the case mix weight of your HIPS code. Keeping in mind, this is a very limited group, and I'm going to show you the low comorbidity group in just a moment. The high comorbidity adjustment calculation requires that at least 2 of your secondary diagnoses group into a specific subgroup where the 2 diagnoses on your claim are in a specific subgroup on the high comorbidity list that each of the 2 categories for those 2 diagnoses fit into. So if it were 2 wounds, then it's not going to work. But if it's a wound and some heart disease that has a specific diagnosis set in the list combined, that would get you a high comorbidity adjustment. If you do get to the high comorbidity adjustment for your patient, you basically have added 15% to your base rate. So it is a situation that is difficult for some to understand in the sense of how to interpret the high comorbidity situation especially. But the reality is, even if you need detail, word for word, minute by minute, step by step, what the high comorbidity adjustment looks like, how it's calculated, exactly what diagnosis codes are listed, you still aren't going to go out and make sure your patient specifically has those diagnosis codes. So what am I trying to say? I'm trying to say that you need to focus on ensuring that your coding staff is coding to the greatest specificity possible and including all diagnoses that is listed as the patient currently having those diagnoses. Also making sure that you are only using diagnosis codes that have been prior documented in physician documentation, and or the patient has been seen or communicated with the PCP to determine it is truly a valid diagnosis for the patient. So this is the list of the low comorbidity subgroups. There are obviously detailed diagnosis codes within these particular subgroups that if that code was listed as a secondary diagnosis on your claim, you would get the low comorbidity adjustment. Do note 2 things. First of all, there were changes from 2024 to 2025. And secondly, note that if you downloaded the original posting of the home health final rule that was released on November 1st, this table was wrong in that final rule. The next week, about a week after it was released, they released this updated list of the low comorbidity subgroups. So you'll want to make sure you are focusing on this list, not the one that was originally published. One very significant change, at least in my opinion, a significant change from last year, 2024 to 2025, is the fact that they dropped the respiratory category from this list that included COVID-19 and COVID-19 related diagnoses. So what does that mean? That means that today, 2024 through December 31st, if you have a patient that has a COVID-19 or not COVID-19 related diagnosis as a secondary diagnosis on your claim, that patient would have received or will receive a low comorbidity adjustment. Beginning with dates of service January 1st, 2025 and later, that category will no longer exist as far as a low comorbidity adjustment is concerned. I did not include the high comorbidity adjustment subgroup list. As you saw on the previous screen, there's over 90 of those categories. So it would have taken up a lot of screen space that I would have been clicking through. You can get the detailed high comorbidity list from the CMS Home Health main page. So the next part of the reimbursement HIPS code that was impacted by this final rule is the functional status, M1800 through 1860, with the exception of 1845, and M1033, risk for hospitalization. Each of these items are still utilized and will continue to be utilized as the catalyst for calculating the functional status, low, medium, and high, of the patient in question. So what I want to point out to you today is two things. Let's go back. One thing I want to make sure you're clear about is the GG items, which we all know are not the same as the 1800s. Those GG items are going to directly impact reimbursement from a value-based purchasing stance, which I will talk a little bit about a little bit later. But they are not the same as the 1800s. And you have to make sure that your clinicians are receiving education specific to the GG items versus the same education you've been giving them for years on the 1800s. While the item's title, question, and even responses might seem similar, they are not the same. For example, the GG section allows for you to, the GG specifically assesses the patient's percentage of need from someone else, and does not take into consideration either way whether the patient is using an assistive device or not. Where with the 1800s, you actually have to pick devices or number of devices, et cetera, that the patient might be using, and it does impact the way you score the patient. So you definitely need to make sure that you are not losing focus of the 1800s as we move into 2025, because the 1800s are still going to directly impact your payment through the calculation of your HIPS code, even though the GG items will now directly impact value-based purchasing. So you've got to make sure that you're maintaining high levels of education in both of those categories. So this screen came from the final rule and is specific to the low, medium, and high percentages that we have seen since the PDGM model began. The low, medium, and high percentile rankings are established based on the response options and points that I will show you on the next screen. But as you can see, from the 2018 and 2019 simulated data, as we began PDGM in 2020, the expectation is that the low, medium, and high categories will be approximately 33% across the board. As we went into 2020 and 2021, you see that the high scoring is 41.7 and 44, which is quite a bit above the expectation of 33 hopeful percent. That being the case, as we went into 2022, based on 2020 data, they made significant changes to the response point allocations so that the result would be lowered. So as you see in 2022, we're down to 38%, 2023, 38.3%. Understanding that CMS is keeping an eye on this on an agency by agency standpoint, and if you have patients that are greater than 38% of your total 30-day payment periods that are in the high functional category, you should definitely be concerned that medical review, possibly targeted probe and educate, is in your near future. So these are the items that are specifically utilized to calculate the functional portion of the HIPS code, the 1800s, and then the M1033. Everything that you see in red is a change. So the ones in the 2024 column are changes from 2023. The changes, or the red that constitutes changes in the 2025 proposed column, are point changes for the coming year, for 2025 versus what we have today in 2024. Understanding also that that column is final. It is not still proposed. And so some key elements I just want to mention is the fact that we are losing, while in bathing, we're gaining points here, points here, points here. When you get down to some of the other categories, this one is losing, 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 losing. Whoops, so sorry. Losing, and then we pick up here, but I'll talk about risk for hospitalization in a moment. The reality is that many more of the scoring for the functional items is changing again for 2025, with most of those being a decrease in the number of points you receive if you answer the question in that way. The risk for hospitalization question has 10 possible response options on the OASIS. So your clinicians have 10 possible ways to answer the question, with numbers 8, 9, and 10 not counting in the calculation of the outcome. And so with the numbers 1 through 7 in the response options, if your patient is acknowledged as being true to 4 out of 7, the top 7, on that risk for hospitalization question, then you're going to receive today 11 points, next year 12 points in the overall calculation of the scoring for low, medium, and high. Keeping in mind that we struggled desperately with the total percentage of 30-day payment periods related to high risk for hospitalization is honestly mind-blowing. If you haven't looked into it ever, the question response options for risk for hospitalization, numbers 1 through 7, are very much, I should say, representative of the large majority of home health patients. And so that's why we struggle with only 41% of 30-day payment periods getting credit for this question. And so one of the options, or one of the responses in 1 through 7, is my patient has 5 or more medications, and that does include over-the-counter medications. And so how many patients have you admitted in the last 10 years in home health that did not have at least 5 medications, including over-the-counter, herbals, etc.? And the reality is very few in this country have less than 5, especially when you count over-the-counter. So that being the case, why are the nurses not marking it? One of the other items is multiple hospitalizations, multiple emergency department visits, changes in the patient's cognitive status. So I could go on for hours, right? Which we don't have time to do today. But you have to make sure that your staff is fully analyzing and assessing, is more the word instead of analyzing, assessing the patient's condition and ensuring they are responding to 1033 appropriately. I also struggle with home health agencies that are constantly complaining that they cannot improve their acute care hospitalization rates, yet their risk for hospitalization question on the OASIS is all over the place, meaning it's inconsistently answered. It doesn't make sense with the charts, etc. This risk for hospitalization question, one of the reasons it's on the OASIS, or to be used from the OASIS, is to help agencies identify immediately upon start of care or resumption of care patients who are at high risk for rehospitalization and then acting accordingly. Many agencies are not using this question to help them identify and determine patients who are at high risk. When it's a question that you already have to complete, you don't have a choice because it's on the OASIS and is directly impacting that patient's rehospitalization rates, whether you like it or not. So if you got to complete it anyway, why not use it for what it was originally purposed? So the next thing is the CBSA changes. CBSA, in case you're new to the game, CBSA stands for Core Based Statistical Area. the core-based statistical area in which basically your county operates from a home health standpoint. And so the CBSA classifications have been upended once again in this 2025 rule. 54 urban counties have now been moved to rural, and that impacts 25 states and the island of Puerto Rico. 54 rural counties have been moved to urban, and that impacts 25 states. Some counties have moved from one CBSA classification to another, and some counties are being moved to different urban CBSAs, meaning they're taking them from one urban CBSA and putting them into another. The comment prior to that really kind of says the same thing, but also included in that statement is the fact that they are, in some cases, just changing the title of the CBSA area, not necessarily moving counties in and out. Finalized in the 2023 proposed and final rule technically, was the 5% transition cap on all wage index changes. If you were to be in a county that is currently urban and it's going to be rural in 2025, there is going to be an adjustment period for you during the year next year as you are first billing under the new CBSA rural status. You will see that there is a drop in wage index in most cases, and that drop in wage index will obviously impact your reimbursement. The drop in wage index cannot be greater than 5% based on this rule that was passed again in 2023. And so in order for you to avoid a greater than 5% drop in the cap, in the wage index, you have to use a temporary CBSA code for 2025. And then once you have gone through enough years to catch up to your rural status, you would go back to the traditional CBSA code for your area. Now, when I say catch up, the thing is, we have seen situations where counties have been moved, especially from urban status to rural status, only to discover that the wage index drop was 15–20%. And that's real, not always for everyone, obviously, but it is, it can definitely be that high in some areas. That being the case, you would have to use the temporary CBSA code and limit your decrease in wage index for each individual year until it caught up with where you were supposed to be with your new rural status. So in the case of 15%, it would take at least 3 years in order for you to get there, because they're, again, restricting the calculation to allow only a 5% decrease from the prior year, regardless of the reason for the change. So that is encouraging, at least. The case mix weights, all 432 possible HIPS codes has its own case mix weight. Those weights are revamped every year, at least they have been historically, and under the PDGM model, more so than PPS, but definitely under PDGM. And when they are revamped, you basically just get a new case mix assignment to each of those 432 based on historical data. In this case, the 2025 one's based on 2023. The budget neutrality factor that I mentioned earlier, the 1.0039, is added into the calculation of the base rate. The LUPA threshold, so each of the 432 case mix groups or HIPS codes has a corresponding LUPA threshold attached. And so basically what that means is with each of the 432 HIPS codes, each one of them has a LUPA threshold that range from 2 to 6 visits. If your LUPA threshold for your particular 30-day claim HIPS code is 4 visits, then you must provide 4 covered visits in order to be paid the whole amount. Otherwise, you will get paid per visit based on the individual visit disciplines that were billed on the claim, and obviously the number of visits that were billed. So if you had a LUPA threshold that was 6 and you did 4 visits, then you're going to be paid those 4 visits under the LUPA calculation, which will result in per visit payments. The per visit payments you see on the screen are the new payments for 2025. These are base rates. Those numbers do have to be wage adjusted before your payment is made. Do note that the LUPA rates are not subject to the behavioral adjustment. So the reduction this year of 1.9% does not apply to the LUPA numbers, thresholds. So I should have said technically rates. So the rates have continued to increase every year since PDGM began, based on the increase in the market basket, etc. Now, with the LUPA thresholds ranging from 2 to 6, and each CBSA code having its own specifically related LUPA threshold, there are 8 of those that have changed for 2025, and each of those have a decline of 1 visit in the threshold. So basically that's good for you, for anyone in home health, because that just simply means if today the LUPA threshold is 4 and next year it would be 3. So these 8 are the only ones that have changed. You can get that detailed list off the CMS website. But the reality is that this is a very good thing for you, because again, if last year or this year in 2024, you had to do 4 visits to get the full 30-day payment, next year you would only have to do 3 if your particular HIPS code in question was one of the 8 that had the change. So the LUPA add-on, I have been quite surprised to find how many have questions about this LUPA add-on percentage and how it works, where it came from, etc., because it's been in place since way back in the PPS system. The LUPA add-on percentage only applies to a 30-day claim when that 30-day claim is the first 30-day claim in a brand new start of care episode. Once calculated, so let's say the patient was admitted, the patient's HIPS code is calculated, the patient's HIPS code results in a 4-visit LUPA threshold, which means you have to do 4 visits to get the full payment. You only do 3 visits. So now you have a start of care episode, first 30-day period. You only do 3 visits, so you don't hit the LUPA threshold, and the patient refuses further care. So it's going to be the only 30-day payment period that you have for that patient, which is part of the requirement to get the LUPA add-on. So once all that criteria has been met, the percentages that you see on the screen are multiplied by the base rate in the LUPA calculations to determine what you're going to get paid for the start of care visit only. So this adjustment does not apply to the nursing and therapy visits that are done just routinely. It only applies to the actual start of care visit on the claim. So the example that you see at the bottom right-hand corner of the screen, you see the 297.09, which was the result of the 172.73 base rate for nursing, multiplied by the LUPA add-on percentage of 1.72%. That giving you a payment for that one start of care visit of 297.09. And that number is the base rate. It does have to be wage adjusted. They did update the add-on percentages for skilled nursing, PT, and speech. They had been the same for a couple of years, so they did update those, and they assigned occupational therapy their own rate. Occupational therapy, since we were given the right to allow an occupational therapist to do a start of care in a therapy-only case where other disciplines had also been ordered, which began in 2022. We did not have a LUPA add-on percentage for occupational therapy at the time because we didn't have enough history of occupational therapists doing a start of care to determine what that percentage would be. So they have been using the physical therapy add-on percentage prior to 2025, and in 2025 it will be 1.7238. This is new information just off the presses, released just this week. New forms have been released for the Notice of Medicare Non-Coverage. So the Notice of Medicare Non-Coverage is required to be given to a patient within 2 days of that patient's intent to be discharged. So you're going to discharge a patient on Friday. You have to give them the Notice of Medicare Non-Coverage no later than the prior Wednesday, in order for the patient to have the opportunity to file an appeal with the QIO, in order to determine whether you are being effectively discharged. That has been the case for traditional Medicare patients for years. From a Medicare Advantage standpoint, prior to 2025, the Medicare Advantage plans would have to be listed as the patient being able to call them and request a redetermination of the decision to discharge the patient. They have changed this starting 2025, where that Medicare Advantage patients will now have the same immediate appeal rights through the QIO that traditional Medicare patients have. So the new forms will require that the QIO information be provided to both traditional Medicare and Medicare Advantage patients. The Medicare Advantage plans will not be able to require you to send the patient back to them for appeals. You will have every right to send these patients to the QIO in order to get an expedited decision on their discharge from services. And so this is big. I think it may be more of a pain to you. I don't think that's the case, because I spoke with an agency yesterday that was saying their Medicare Advantage plans require them to put the Medicare Advantage information on there, the plan information for them to contact for appeal. Now that will be the QIO for everyone. Just make sure that you ensure you have a stringent enough policy in place so that all of these are being delivered to the Medicare Advantage patients as well as traditional Medicare patients. And the expiration date on the bottom of the new form is 11/30/2027. You must be utilizing the new form as of January 1st, and do understand surveyors can issue a citation if you are not using the most current forms. The disposable negative pressure wound therapy devices. These devices are disposable wound vacs, where the patient comes home with the device attached to the wound. You remove the device, throw it in the trash, and put a new device on. That disposable device was required to be billed on a separate 3-4 bill type prior to January 1st of 2024 in order for a home health agency to be reimbursed for those devices. Now effective January 1st of 2024, so we're 11-12 months into this, you are now required to bill the nursing time that is spent in providing this care, this wound care, on your home health claim as if it were any other skilled nursing visit. And in addition to that, you must use the HCPCS code A as an Apple 9272 for each of the devices that you provided to the patient during the 30-day period you are billing for, in which case the A9272 code will be reimbursed today at $270.09. Next year, that amount will be $276.57. The next thing I want to talk about is how the value-based purchasing model is impacting your reimbursement, especially as we move closer to 2025, when we will for the first time see either payment increases or payment decreases as a result of your total performance score. We're also going to talk about 2025. 2025 brings multiple changes to the value-based purchasing model. Some of you may be thinking, why is she talking about this with billing? These are direct reimbursement related issues, and with the value-based purchasing adjustment based on your 2023 performance, you're going to have to know from a billing standpoint what the reductions are from the claim on the remittance advices, so that you are cash posting appropriately and you can ensure that you were paid appropriately. For the update of the new measures to this screen, these measures that you currently see in the first two columns, but there is a blank in the right two columns, that means that you will not see those items in the 2025 measures. So discharge to community, the current one that we have is an OASIS-based item, will not be in the calculations next year. If you drop down to the claims-based measures, you see a discharge to community post-acute care measure that will be its replacement. The current measure being based on OASIS, the coming measure being based on claims data. The dyspnea and oral meds will remain, but their percentage of impact has changed. Total normalized composite change in mobility and self-care will both be removed, which are the 1800s. The discharge function score based on GG items alone will represent 20% of your score. The acute care hospitalization and emergency department measures will be gone and replaced by the potentially preventable hospitalization measures and discharge to community measure we already spoke about. So those will be the two measures that create the 35% threshold. And then we have the HHCAPS measures that will continue exactly the way they are today, and their percentage of impact has not been changed. So we have a question in the queue. Is the disposable negative pressure wound therapy, if it was supplied by DME, do we still need to include it on our billing to Medicare? And the answer is yes. In order for that item to be reimbursed, you would have to bill it on your claim and receive the reimbursement. Can you confirm if Kinzer, also known as WellSky, will follow values? I don't know what you mean when you ask if WellSky will follow value-based purchasing. I have no idea what you're asking. If you can rephrase that, I might be able to help, but I'm not sure what that means. Okay. This is from your annual adjustment report. The value-based purchasing model has been releasing interim reports since July of 2023 for the new value-based purchasing expansion. Then in August of this year, you should have received the first annual report. In September, October, we received the second adjustment report, and we are now waiting for the final report to show the total performance score adjusted payment percentage that will apply to your payments in 2025. This agency sees a negative 1.366% taken from their payments. So on their remittance advices, They will see a reduction in every single claim payment with a date of service on the claim from 2025. They will see a reduction to their total payment of 1.366%. And so these agencies are definitely going to be thankful that the changes in the base rate resulted in a positive impact instead of a negative if they're going to have money taken away. There are going to be agencies that have reductions based on the case mix weight and wage index, and then this value-based purchasing adjustment on top of all that, where others are going to have a positive result from value-based purchasing that will see money added to each of their payments. So you'll need to make sure you check the iKey system if you have not been doing so routinely to ensure that you have the most current reports and to know for sure what percentage will be deducted from your payments next year. This is a list of the current resources for the home health value-based purchasing expansion, including this new email address. It's probably 4 or 5 months old now, but this is the email address you should be utilizing if emailing CMS about specific value-based purchasing questions. These measures that you see on the screen are measures that they intend to use, that they intend to implement in value-based purchasing in the future. These were put into the proposed rule basically as requests for information and comment. They have not laid out exactly how those measures will look and stated that they would not be put into value-based purchasing any earlier than 2027. The remaining time that we have today, I want to take you through some managed care billing situations. And when I say billing situations, I don't mean specific billing problems or criteria. This is the thing. I spoke with our billing director when I was putting this PowerPoint together just to ensure that I hadn't missed something that was recently a big issue or a big deal. The reality is the managed care situation remains that the majority, by a large margin, of denied claims are as the result of a lack of authorization, specifically in most cases, a reauthorization after the visits that were approved with the original authorization have now expired or you have used them all. And so we're going to talk primarily today about walking yourself through a managed care referral and then the authorization verification and talk about some things related to that toward the end. So when you get that referral, you obviously have to identify for sure who the payer is. So we have a lot of these billing struggles where agencies assume that because the patient was presented to them with a Medicare MBI number, that the patient is automatically traditional Medicare. That cannot continue. The managed care plans cannot use the patient's Medicare MBI number as their identifier. They have to have their own. But even if a patient has an MBI, that does not mean they are not in a Medicare Advantage or Medicare managed care plan. You need to make sure that they are currently enrolled in whatever plan you thought they were by doing the Medicare eligibility verifications. Not always is it going to be updated. I understand that, but you definitely cannot make assumptions without checking the file. You need to not only determine through the eligibility process that the patient has a particular plan, you need to verify that coverage with the plan. It really gets sticky and ugly in January each year because of the fact that so many people during open enrollment make changes to their current policies. And with those changes, they do not always get updated by January 1st. So you have to make sure that you are not only, again, seeing it in the eligibility file, but verifying that coverage with the actual plan. Make sure you confirm the network status, meaning which network, which plan specifically they're in, determine if authorization is required, and make sure to use all of their portals. Someone has asked the recommendation of the best site to check eligibility. You simply need to make sure that you have access to the Medicare eligibility file through the HET system. So whatever system you're using, we use Waystar, for example, and Waystar definitely accesses the HET system, which is the system that has the Medicare information contained. Make sure you're not using some off-the-wall system that doesn't necessarily give you the correct information. HETS, H-E-T-S, is the acronym for the system that you should be pulling those those eligibility files from. Another question says, are managed care plans allowed to reimburse less than the Medicare Medicaid rates? The answer is managed care plans will reimburse you whatever your contract says they're going to reimburse you. If you do not have a contract and they pay you out of network, typically if it's a Medicare Advantage plan, they will pay you episodically. But in the case of contracted managed care plans, you are going to get whatever you sign for in the contract. And in 99% of cases, those rates are going to be less than the traditional Medicare rates. Ensure your policy is current. Policy meaning with the insurance plans that you're accepting patients for, so that you can ensure you stay on the right road of setting that patient up appropriately in your system so that the claims do come out on the other side. Out of network, check on the cap of services, meaning if you, the home health agency, are out of network with the provider that you have accepted a patient for, it is very possible that you're going to have to get a one-off contract or an agreement to see that patient with the stated rates that they're going to pay you. But do make sure that in an out-of-network situation that the patient has not already met their cap for a certain level of service. If that were to be the case, then you will not get paid. Co-payments and co-insurance are extremely important. Make sure you check on the status of those for each patient as you are admitting them. Verify every client every time, meaning just because you had a patient 2 months ago does not mean their insurance has not changed. And check for any open Medicare secondary payer files. Someone has asked, some require an NOA, but it's hard to know which ones. That is a one-off situation, meaning some managed care plans do require a face-to-face encounter, others do not. You will have to get very specific with the plan in question. I got off on face-to-face, not the notice of admission, which was the question. But while I'm there, some do require face-to-face, some do not. But the question was about notice of admission. In some cases, these Medicare Advantage plans don't even know what a notice of admission is. If they are paying you episodically or you are required to bill them episodically, they will likely require an NOA, but not always. You are going to have to check individually with each individual plan to determine if an NOA is required. Some common missteps in the process of admitting patients: not having accurate client demographics, make sure you discuss this with the patient specifically or with a power of attorney if one exists, to ensure that you have all of their correct information, including birth date, address, etc. Many make the huge mistake of not identifying a primary care physician immediately so that you know who is going to sign orders for this patient. You cannot go through the process of admitting and treating a patient without having confirmed that a primary physician is going to sign your orders and then confirming that they agree with any treatment that you provide to the patient before it is provided. Make sure that you're using the correct forms or portals for the specific plan in question, meaning don't assume because you have access to a United Healthcare portal that it is the correct United Healthcare plan portal, meaning they have many different plans under the auspice of United Healthcare, but which of those plans are included in your contract and specifically what forms they require and portal access might they have for those specific plans. Make sure you have the provider manual handy and make sure that someone in your organization has become familiar with that provider manual enough that you can ask questions and help analyze why you are not getting paid what you had thought you were going to get paid in the beginning. And make sure that at least monthly for the first quarter of any given calendar year, you are verifying benefits still exist, meaning you're verifying with the payer that the patient has not changed plans, has not been terminated from the plan, etc. So basically doing an eligibility verification each month to ensure that patient still has the same coverage. Authorizations, some pearls of wisdom. With an authorization plan, meaning a plan that requires you to get prior authorization, which is 99% of them, you need to understand what that process looks like. In some cases, it might be advance notification, meaning you're notifying them that the patient is being admitted versus actually getting a prior authorization, but prior authorization is typically the case. Confirm the skill levels that have been authorized for the patient specifically, making sure that you are fully clear what your contract allows. In some cases, contracts that say physical therapist specifically mean registered physical therapist, not assistants. In other cases, you can use either one. Same thing applies to RNs and LPNs or LVNs. You have to understand exactly what your contracts allow and what the expectation is as far as attaining the authorization. If you have non-routine supply orders, request an authorization to be paid for those. In some cases, your contracts will not allow for payment for non-routine supplies. In other cases, it will. And in cases where it does reimburse for supplies, you excuse me, may have to have very specific supply lists that they will allow payment for. A question has come in, is there any public site we can check to know if the patient has Medicare applications pending? I only ask because we have a couple of admission episodes where we had payer changes that retro off nearly 6 to 8 months to when the patient had applied. We had been getting authorization through the previous payer that we thought was accurate, but now they have Medicare primary since application was approved and reauthorized, but we have no NOA and was unable to bill Medicare. Is there any recourse on how to look for those pending applications or on how to bill for that care through Medicare months later? So that is a very good question and a very good scenario. So first of all, I do not know if there is a place for you to check on pending applications. I'm sorry that I can't give you that information. I do not know. Questioning the family, questioning power of attorneys that might exist for the patient, etc., may be the only way you're going to know. But as far as the Medicare billing is concerned, if you're able to prove that the system was updated after the fact, they know the date that they put the patient was Medicare eligible in the system, and they will allow for you to bill with the notice of admission being late and then you requesting an exception to the late notice of election because the Medicare system was not updated with the patient information as the patient being eligible for Medicare when you originally admitted the patient. There really should not be a big issue with you doing that as long as you do it within a few weeks of the time that the Medicare system got updated with that information. So I can't tell you that there is a specific timeline. within a few weeks would be ideal, but you definitely can do that. On the final claims, you will use a KX modifier on the HIPS code line, and in the information, what's the word I'm looking for? Remarks section of the claim is where you would explain the situation. And in this detail case, there may be a request for additional information. And the person is asking, how would our billing company know how to do this? No, would our billing company? I don't know who your billing company is, but if your billing company doesn't know how to request an exception to a late NOA, I would be concerned. Okay. Continuing with the authorizations, thought process, tracking reauthorizations absolutely has to happen and is one of the number 1 reasons why an authorization or why a claim is denied. So the number 1 reason is lack of authorization, but 99% of the time it is lack of reauthorization, meaning you got an initial authorization, but that initial authorization ran out. You may have gotten an original authorization for 4 visits. You did the 4 visits, and then somebody dropped the ball and didn't get a reauthorization for the next 3 or 4 visits that were needed, yet the clinician went ahead and saw the patient. So you have to make sure that you have a hardcore process within your organization to determine when that new reauthorization has to be initiated, and make sure that your EMR system puts controls in place so that your clinicians cannot schedule visits without an authorization when authorizations are required for specific visits. Ensure the correct physician is identified upon admitting the patient, not weeks later, so that there is no concerns with who will be signing your orders. Fill in any forms or information that are required completely in the authorizations process. Advocate for your clients, meaning when you don't get the visits that you've requested, you need to fight for them to get the care that they deserve. One of the things that CMS has said that they are heightened aware of recently is patients that are not receiving the care through Medicare Advantage plans that they are due to lack of non-authorization or denied authorizations, I should say. The rights of authorization, there are 5. The right agency, the right NPI number, the right patient, the right services and codes, and the right dates of service. So what does that mean? That means that when it says right agency, we know the correct home health agency contract associated with the payer is the agency that is requesting the authorization. Correct NPI number of that organization is in the contract. The right patient, obviously you need to make sure that you are requesting authorization for the patients that have actual coverage under the plan in question, that the services and dates you're requesting authorization for are accurate to the care plan, and the dates of service that you are asking for are specifically the ones that you need help with, or that you need an authorization for. Patient's full name, address, birth date, preferred phone number, and an alternate phone number, diagnosis codes that support the need for care, including but not only the primary diagnosis, and an attestation for home health eligibility from the physician is common information that the plans, the managed care plans, may ask for in order to give you an authorization for the patient. They're going to need the start of care date, physician orders when needed services are clear, meaning if we know exactly what we're going to do for this patient upon admission, you need to identify what those physician orders are and be prepared to share that with the managed care plan. The ordering physician's name and NPI number, obviously, primary care physician and insurance plan and group information. Some require OASIS and an initial therapy evaluation, often within 7 days of the start of care. OASIS is not already, if the OASIS is not already provided, and obviously if it is a skilled patient. Keeping in mind that as we move into the traditional Medicare requirement for those Medicare certified agencies to complete OASIS on all patients, regardless of payer, that is really not going to change anything here, because today, if you have a skilled Medicare Advantage or skilled managed care plan under Medicaid, if the patient's receiving skilled service, you already have to do OASIS and transmit those to the database. So that change rule really doesn't change anything. Relevant clinical documentation to support services. Obviously, initially, you may be able to get an initial authorization for a few visits. After that, you're going to have to be able to provide documentation to support the patient needs continued services. Make sure in the cases of Medicaid, which is different from state to state, that you have the specific information that is required for that state, that you're compliant with EVV. And to ensure that any prior authorizations or do not increase hours. Meaning, if you have an initial authorization for a certain number of hours a week and the physician orders increased hours, you're going to have to go back likely through the authorization process to get those additional hours authorized. Letters of agreement, and this is basically the one-offs that I talked about earlier. When you are not in network with the managed care plan, the letters of agreement are going to show that the payer is agreeing for you to provide the services to the patient, even though you're out of network. They are going to identify in these letters of agreement what they're going to pay you, what codes they're going to pay you for, the visits numbers that have been approved, and make sure that you have that information reflected appropriately on the claim. Case management, make sure that you are looking at each and every patient individually and have people that are truly case managing the situation, including ensuring that reauthorizations occur and that you're not waiting to the last minute expecting retro authorizations, because most of the time those are not going to happen anymore. Make sure that you're utilizing your electronic health records to ensure that you have what your patients need. In order to be successful with managed care plans, it is truly a team effort. You have to be consistent. One of the things that I don't technically have a screen for today is payer setup. So as you are conducting a new payer into your organization, so you sign a new contract or you get a new letter of engagement or a letter of agreement from a managed care plan that you are not in network with, you have to set those payers up in your system to ensure that they are plan by plan, not Medicare Advantage organization by Medicare Advantage organization, but plan by plan. In other words, just because it's United Healthcare does not mean the payer setup for their 500 different plans is the same, because most of them are completely different. So do not allow whoever is setting up new payers in your EMR system to copy and paste from one payer Medicare Advantage organization to another, but very detailed setup specific to the plan that is in question, so that you can get a clean claim out to that provider and hopefully get paid effectively and timely. Request provider training if necessary, meaning training, especially if you have contracted with the managed care plan. You may not get the training, but at least you can ask. And they will possibly be able to identify resources for the training even if they're not going to give you one-on-one training from the organization, like things that they have already pre-recorded, etc., that might assist you in being effective with their patients. Okay, so we have a few minutes for questions, and we do have some in the queue. If you have not submitted a question yet, please do not hesitate to do so. There is a recording, there will be a recording, and that recording link will be sent out, and it will be posted as a free webinar on our website. Calling Medicare for the above scenario will walk you through what will need to be done and how to do it. No, Medicare is likely not going to walk you through how to request an exception, but the details are in the Medicare claims processing manual. We've had an issue in our organization where the Medicare Advantage plan was not aware of a patient under the hospice program. We received the authorization for home health. The home health portal does not show patients enrolled in hospice. There was no way for us to know the patient was enrolled. The patient never disclosed the enrollment in the hospice program. We are still fighting the claim. You are likely not going to win. If the patient was enrolled in hospice when you did the Medicare eligibility verification, within 5 days of the patient being admitted to hospice, there should be a notice of election that has been sent into the system if the hospice expects to get paid, in which case you should be able to identify that the patient is actively in hospice. That being the case, I just simply don't believe that you're going to receive payment for those claims. I have been a billing company, home health and hospice, for 15 years. Yesterday, the owners had a meeting with an AI billing company. They want to bill all claims from their own system with no right back to our EMR. Do you have a home health or hospice using AI with no claims reconciliation or EMR or in EMR access? So I do not have any billing clients that are using an AI system that does not come back to the EMR system. We are a billing company, as I shared earlier. We utilize each individual agency's EMR systems. However, we do export the claims from those EMR systems into Waystar, excuse me, to the Waystar system, and the Waystar system then transmits them on to the Medicare system, and we monitor remittance advices, denied claims, rejected batches, etc., all through the Waystar system. So I'm not really sure what this AI company is proposing to be able to more effectively answer that question. When the patient appeals with the QIO and wins, how quickly will the Medicare Advantage issue authorization? It states that their care continues during the appeal process. It seems that this holds us to continue services even if we don't have authorization. This could be a determinant to agencies when the Medicare Advantage refuses to authorize. It's going to be a good transition, for the Medicare Advantage plans, and I'm sure it isn't going to be fun for a short time until they get what they're not going to be able to patient services so early. So when a patient receives the notice of Medicare non-coverage from you, they have a certain period of time to initiate a request for appeal through the QIO. The QIO has a very limited time to respond to that. Now, this is the thing. If you are discharging the patient due to the patient no longer needing services, no longer qualifying, because that is usually the case with a traditional Medicare patient, and the QIO comes back and says, oh, but they should get additional services. If you know, based on traditional Medicare regulation, that patient no longer qualifies for services, you should not continue the care of the patient, and you are not forced to do so. With the Medicare Advantage plans now being added, most of you are probably discharging Medicare Advantage patients, not because goals have been met and services have been provided accurately, but because the Medicare Advantage plan is refusing to provide authorization for the care needed. If the QIO were to determine that they should be providing the authorization, then I am thinking that they will be forced to pay for the services that the QIO says should have been authorized. It is still a waiting game, to be honest, and we are not exactly sure how those are going to play out. Okay, let's see. Authorization log or spreadsheet that could be used to track the multiple ongoing authorizations for several patients that we have that I'm willing to share. We do not have a prior authorization tracking sheet or spreadsheet. Most agencies that do not have an adequate system within their EMR system are simply using a Microsoft Excel spreadsheet, putting in the date of the initial authorization, the number of visits, at what point those authorizations would be expiring, if you know that. So if it's the patient's been authorized for 4 visits and you know they're going to do 2 visits a week for the next 2 weeks, then putting the date that you need to begin that reauthorization process and then monitoring it accordingly. Sorry, I couldn't be of more help there. The temporary code for your CBSA. So if you were being moved from an urban to a rural status with your CBSA classification, which will trigger a decrease in your wage index, and in some cases greater than 5%, your temporary CBSA code is listed on the wage index codes spreadsheets from CMS in the content of the final rule, and is listed by county. So if the county changed, if it's going to have greater than a 5% decrease in wage index, you should see the 50 is the first 2 letters, numbers of the temporary code. So if you see a 50 code as your CBSA code, that's the code that you will definitely use all of 2025 and possibly into 2026, depending on how much more your wage index is going to drop. While I am finishing up the remaining parts of these questions, or the remaining questions in the queue, we do have an additional polling question that we would like to put out there. If you could respond to that as we continue answering questions. How will the patient being readmitted back into the... Yeah, I'm not sure what, Gloria, what you're asking about the readmitted to hospital means. Can you please expound on that question? Is United Healthcare Plan the only managed care that pays $90 a visit? Is there any way to help us negotiate rates? My company does have a managed care contract negotiator on staff. So we do have contracts where we are assisting agencies with contract negotiations in all types of managed care plans. I cannot speak to the specific dollar amount per visit that you mentioned, but we can look at contracts and determine whether there is any help there. Is there a list of cities for the CBSA changes? It's not cities, it's counties. And again, in the CMS final rule, there's a link to those CBSA changes. Again, that list is by county. Will the recording will be available, and anyone will be able to access that free webinar from our site. The discharge function score in OASIS that is based on the GG items, the only way that we know of that you can currently see what the anticipated discharge function score will be based on the GG items is if you have the SHP software, Strategic Healthcare Programs, and you have the Einstein version. The Einstein SHP version does have the discharge function score calculation and has been running it for about 6 months. The potentially preventable hospitalization measure, what claims that's based on, does this mean it will still be based on claims for all institutions? So the potentially preventable hospitalization measure is going to be applied to any rehospitalizations your patient has during the home health stay. Currently today, the acute care hospitalization measure is any rehospitalizations the patient has from the time of admission through 60 days. So start of care to 60 days. If your patient goes back to the hospital, whether they're still on service with you or not, it counts against you. In the new potentially preventable hospitalization measure, it's if the patient is rehospitalized or held in observation for a diagnosis that is considered to be potentially preventable. And the only way you know if it's considered potentially preventable is if you have the list of diagnosis codes they published in the rule that tells you whether the diagnosis was considered to be potentially preventable. Okay, it looks like our questions are done. This screen, well, it was that screen. Here it is. This screen gives you the information regarding our company, the link to send us specific questions. That info at email address goes to several people in our company that can get you an answer, preferably within 12 to 24 hours. We want to thank you all for participating in our call today. You can also go to healthcareprovidersolutions.com to learn more information about our Alliance membership, and the QR code that you see on the screen. You can schedule a call with our sales team to discuss any services that you might potentially need for your organization. Again, we want to thank you all. We hope you had a beautiful Thanksgiving and hope you have a fabulous Christmas holiday ahead. Thank you, and let us know if we can assist in any way.